Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Doctors Prystajecky of Internal Medicine, Henry Bi of Anesthesiology, and Tousief Hussain of Orthopedic Surgery at the University of Saskatchewan discuss management of antiplatelet therapies around the time of orthopedic surgery. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So our objectives for today's talk are just to discuss newer orthopedic literature on VT prophylaxis. So for those of us that are on the wards and we see this aspirin, we're like, this is interesting. Okay, we always put in our consult notes, VT prophylaxis as per surgeon. So I'm not going to argue too much with what the surgeons do. Not very often. Then we're going to discuss antiplatelet agents around the time of surgery. But first, I want to start off with two different cases that have a different approach to their anticoagulation. And then kind of at the end, when we wrap up, we can maybe have an open table discussion on what's the optimal approach, or even is there optimal approach. So the first case is a bit of a personal case to me. It's my dad, and it was kind of funny. Like, he had his knee surgery 10 years ago, had warfarin at that time because that's what they had, did fine with that. And then, so he's a 78-year-old male, had his knee surgery done last year. He's had a history of cardiac disease with stents and a bypass. He's usually on aspirin, usual cardiac meds. So post-op, did all the correct things, put on rivaroxaban for post-op VT prophylaxis, did really well after surgery, went home on day 3. However, day 4, back in swift current, my mom texted me, "Your dad's not doing very well. His leg's really swollen and it's purple and he's really short of breath." So the usual daughter, you just say, "Well, please go to the hospital to get assessed because I can't diagnose you over the phone." So he goes to the hospital, and his hemoglobin is about 80. He's really short of breath, can't even walk up or down the stairs. And so he does get a transfusion because his pre-op hemoglobin is about 150. So he's lost about half of his hemoglobin, and bleeding is ongoing. So the lovely physician in the Swift Current Hospital had phoned the orthopedic surgeon on call, and they're like, "Well, just stop the rivaroxaban and keep him on his aspirin." We're like, "Okay, we can do that. That'll be okay." "What dose of aspirin?" I'm like, "Just take 325. I don't know, mom and dad, just pick a dose and stay on it for a bit and then go back to your 81. And then case 2, I got a text from one of the anesthesia physicians that does the race team. And it was one of those texts like, "What are we doing with VT prophylaxis? This person's on some aspirin. Is the normal thing?" I'm like, "I don't know what we do." Anyway, so it's a 96-year-old male who was admitted to orthopedics with a left periprosthetic distal femur fracture. He had his surgery, then unfortunately had a fall in hospital, and then had a right periprosthetic distal femur surgery or fracture and had surgery. And so he had 2 surgeries within a span of like a week. He was put on aspirin for VT prophylaxis post-op. And then the race team was consulted day 1 post-op from the second surgery because he was hypotensive, tachycardic, and had decreased SATs. So they came and resuscitated him. Orthopedics had ordered a CTP study, and he had a significant bilateral PE and right heart strain. So his aspirin was stopped. He was started on IV heparin for the treatment due to his size of the PE, plus he also had some renal dysfunction, and in discussion with hematology, and then initially transitioned then to tinzaparin after a few days, anapixaban, had an IVC filter in, had a GI bleed, so had many other complications as well. However, that's kind of his story. So one gentleman on aspirin and had a pulmonary embolism, another gentleman on rivaroxaban and aspirin and had a post-op bleed. So, what is the right post-op anticoagulation? Is there an optimal agent? So this is what our rounds are going to be today. So I'm going to invite Dr. Hussain to come up to do his presentation.
Okay, good morning, everyone. So as I said, I will be talking about the orthopedic perspective on thromboprophylaxis. So we'll get started with that. So just a little bit of epidemiology for everybody. So most people know that there's a background rate for DVT. And that's about 80 cases per 100,000 people is what they believe the annual incidence. And then after elective general surgery, PE, which is the thing that we all worry about, is of a rate of 0.1 to 0.8. Elective hip replacement, 2 to 3%. And then after hip fracture, 4 to 7%. So orthopedics is one of the big groups that has to deal with this problem. And then if you have no thromboprophylaxis at all, that for patients who are hospitalized, you can have a pulmonary embolism rate and a death rate of about 5 to 10% in hospital. So important thing to consider for a lot of groups. So there are a lot of treatment options. We go from mechanical, which is intermittent pneumatic compression stockings, aspirin, warfarin, the heparins, factor 10A inhibitors such as rivaroxaban, and then direct thrombin inhibitors such as dabigatran. So as we've seen, there's a lot of choices and a lot of confusion as to why there are so many choices. What should we use? So we look to guidelines. And so we're going to go back a bit in history. And so when I was an orthopedic resident, we had the CHEST guidelines, which were considered the standard of what we should be doing for practice. And back in 2004, they came out saying, we do not recommend the use of aspirin, okay, 1A. So they were saying strong evidence indicates no benefit. They recommended instead the low molecular weight heparins, fondaparinux, warfarin. So another 4 years go by, and they come back out with their next group, next set of guidelines for anticoagulation. And it's the exact same thing, except that they're now saying, how long should we anticoagulate people? So they're saying knee surgery around 10 days, hip surgery, 35 days. And again, strong evidence supporting this. After this is where things start to change. And we have what we call the pulmonary embolism prevention trial. So it's one of the first trials that looked at aspirin and looking at no thromboprophylaxis. And what they found that aspirin was effective in decreasing the rates of DVT and pulmonary embolism. So you can see in the bottom of it, they talk about decreasing this by about a third. So there's some evidence that comes out saying we support the use of aspirin. So another part that comes out as we're looking at the next iteration of guidelines is that big pharma has a big role in playing with what sort of comes out as recommendations. So what was being found out is that the people who were writing the recommendations were also being subsidized by big pharma. And a lot of their research was being done was based on this work. And so they'd come along saying, aspirin is bad, low molecular weight heparin is good, and all the newer agents that were being studied were always the best ones that were coming out. And in fact, they came out now after this saying that people who were involved in research may have a conflict going on, and they recommended that those people not be members of the guidelines that were coming out because of this conflict of interest that was being seen. And so there was a study that was done also by one of the orthopedic groups looking at this industry-funded studies, and they found 71 eligible articles. 52 of them were sponsored by big pharma, and then only 2 of those 52 had a negative outcome. The rest were all positive, indicating that these were the right things to be doing. So there was a big fight between the orthopedic literature and big pharma for anticoagulation that occurred. And the next set of guidelines that came out for VTB, venous thromboprophylaxis by CHEST was back in 2012. And now in this guideline, it came in line with what the American Academy of Orthopedic Surgeons wanted, which was that aspirin be included in these recommendations, which include the low molecular weight heparins, the dabigatrans, the apixaban, and the newer agents like rivaroxaban. So that's what started to happen because there was evidence starting to suggest this, which was being pushed by the orthopedic community. And with that, we started to see a change of things happening. So we started to see an increase in the use of aspirin. And here's one of the major studies that look at the use of aspirin now versus the low molecular weight heparins in trauma populations. So this was a good study, 12,000 patients, there's 6,000 in each group, and they looked at the comparison of aspirin versus low molecular weight heparin with a hypothesis that aspirin was not going to be inferior than a low molecular weight heparin for treatment of venous thromboprophylaxis. And so if you have a look, this is their results. And what you'll find is that, you know, the death related to PE, very similar. Low molecular weight and aspirin, we had 4 versus 5. And then for DVT, we had a little bit higher rates of aspirin versus the low molecular weight heparins, but good evidence to suggest that aspirin was a good effective treatment. So then as we kept looking and we started to see changes happening, we started to see the trends of prophylaxis. So this is, in the United States, they had a look at over 120,000 operations that were done in orthopedics. And of this, what were the agents that were being utilized? And so we have things like aspirin, we have enoxaparin, we have warfarin, rivaroxaban, so the more common agents that are commonly used. And what we found is that aspirin turned out to be the most effective out of all these groups, which was the interesting part because they had a PE rate of 0.6. They had a DVT rate of 1.6. They had a good result, and that they also had less bleeding. And that's an important thing in the orthopedic community because bleeding in a postoperative wound can be a big problem. As we get a hematoma developing, we worry about infection, we worry about wound dehiscence and problems with that. So we have evidence to say that if we can avoid bleeding complications, we have better outcomes. But the evidence is also a bit murky because there was a whole change in the way that orthopedics was dealing with patients now. When I was a resident, we used to have people come in a day or two before. They'd come into the hospital with their suitcase and they'd get their blood test done, all these other tests done before they had surgery, and they'd stay in hospital for over a week. Now we do outpatient surgery. So we're changing the way that we do things. And that's a trend across North America now. And it's believed that the changes of getting patients up quicker, getting them to mobilize and move, giving them better anesthetics, that's also part of this wave of change that is contributing to a lower incidence of DVT and pulmonary embolism. So then we looked at biases, and this is again another study that was done by the arthroplasty groups, and they looked at is there bias in what we choose. They looked at warfarin and aspirin. Again, what they came out was similar results showing that aspirin was effective versus warfarin in knee surgery and hip surgery. So this is a table showing those results. There's their conclusion. So we had another look at what about bilateral total knee arthroplasty versus single arthroplasty, aspirin versus warfarin. So that one was a good one as well. And what they found that was aspirin was more effective than warfarin for the prevention of venous thromboembolism. They found that if you had bilateral knees, to no one's surprise, that was a higher rate of having a DVT and a PE than if you just had one knee. And it was significantly higher than other factors such as obesity, age, length of surgery, having two surgeries. And it makes sense that you've got a double hit to the coagulation cascade, so they're going to have higher rates. So then we go back to that article I told you about. This was over 120,000 patients who were involved in the study. And the other part I was going to show you here's a slide showing the change of how orthopedic surgeons started to do their anticoagulation. Back in 2016, 32% were using aspirin. 2021, 70%. And all the other regimens were decreasing. So we can see that in orthopedics, aspirin is leading the way now for thromboprophylaxis. And then the last thing, just for you, this is the Saskatchewan formulary, which shows the cost of these drugs when they're supplemented by the province. And you can see like the pills are much cheaper than injections. And then the other thing, one of the trials came out with, which was interesting, in the trauma ones, were almost 70% of patients wanted the aspirin. They don't want to be poked with a needle. So they're saying, I'd rather have aspirin if the results are the same. And so we're starting to see those trends as well in patients wanting it.
All right, good morning. I'm Mike Prystajecky. I'm a general internist here in Saskatoon. And when we were preparing for rounds, Jill sent me the patient's information for the case. So I looked at the case and I immediately realized that it was Jill's dad. And as I was looking through the consults, I realized, oh God, it's me who saw Jill's dad in pre-op consult. And I'm pretty sure if he saw me again, he would probably say, no one makes me bleed my own blood. So what I'm going to be talking about today is antiplatelet management in the perioperative setting. Previous rounds, we've really focused on DOACs, et cetera, but we're going to talk about aspirin mainly, but also Plavix and ticagrelor. I'm hoping to impress on you that perioperative bleeding has major implications for patients, and we should maybe attend to that more than we have in the past. So why does bleeding matter? This is data published from the VISION cohort It was 40,000 patients who underwent non-cardiac surgery. And when they analyzed the entire cohort, what they learned is that major bleeding was the most common postoperative complication occurring in 15% of all patients. And if you look at the orthopedics subgroup, it was 31% of patients. And they defined major bleeding as bleeding that resulted in a drop in hemoglobin to less than 70, required transfusion of 1 unit of blood, or required intervention. Now, having said that, that is a lower bar for what constitutes major bleeding than in most studies. In comparison, if you look at VTE, it only occurred in 0.7% of patients in this entire cohort. And if you look at the orthopedic population, that rate was 1.6%. So major bleeding, much more common than VTE. And the timing of bleeding matters because that'll influence when we want to restart antiplatelet agents postoperatively. So this was a recent study, subgroup analysis of the VISION study. And what they showed is that most of the bleeding is going to happen in the first week. About half of the bleeds are going to happen the first day or two. 3/4 are going to happen in the first week. And then after that, the rate of bleeding stabilizes. And importantly, major bleeding predicts an increased risk of mortality. And when you consider the hazard ratio as well as the incidence, it's the leading cause of death. They stay in the study. Now, having said that, you can't imply causality from an observational cohort study. But still, it suggests that major bleeding does carry significant morbidity and potentially mortality for patients. So this is kind of the typical framework that we use when we're trying to decide what to do with antiplatelets, anticoagulants perioperatively. You know, we're trying to balance the risk of bleeding and thrombosis, but I honestly think this is not the right paradigm in the perioperative setting. I think it's more like this. So this is a Ouija board. And I think, sure, you know, we're trying to balance bleeding and thrombosis, but the other piece that's missing in that typical framework is the urgency of the surgery. And that's also an important determinant of, you know, how long we wait between the last dose of the antiplatelet and when the patient goes for their procedure. Another way to look at it too is each of the involved parties is going to have a different perspective, different priority. So as internists, we really focus on the thrombosis piece. On the anesthesia side, especially if, you know, the patient's going for neuraxial, the concern is around bleeding because no one wants an epidural hematoma, and the surgeons just want to get the surgery done so that the patient can begin the recovery. And then let's not forget there's a patient at the middle of all of this. Okay, so how do we define bleeding risk? This is the same scheme that you'll see in the CHEST guidelines in Thrombosis Canada. The important thing to remember is that any surgery where the patient's undergoing neuraxial anesthesia is high risk. But there's also those that are very high risk. So spine surgery, intracranial, posterior chamber of the eye, those are really important to keep an eye out for because even if the patient is at high cardiovascular risk, you may consider holding the patient's antiplatelets in those settings. So we've chatted about how to assess bleeding risk. What about the risk of thrombotic events? The important thing is the time from their last cardiovascular event. That's probably the most important determinant of the risk of complications. So this is a observational cohort study of Americans in the VA system. And what they showed is that if you had a stent placed and then you went for surgery, your risk of subsequent cardiac events was highest right after stent placement, and then it went down over time. And that risk really seemed to stabilize at about the 6-month mark. And it's interesting, the same trend is seen with stroke. So if you had a stroke and then you go for surgery, if you go for surgery immediately after that stroke, you're at a very high risk of recurrent stroke, but also other major adverse cardiac events. So for example, like in that first 3 months, your odds of having a recurrent event is 14%. I think the absolute numbers was like 17%. And then at that 6-month mark, you're looking at odds of 5. And then thereafter, the risk starts to stabilize again. Okay, so how do we manage antiplatelets knowing what we know about the risks of thrombosis and bleeding? We chatted about the PEP study previously. Interestingly, the patients started their aspirin before they went for surgery. So this is probably our biggest study to look at the effects of aspirin on perioperative bleeding. So they gave patients 160 of aspirin. They started before their procedure, and most of the patients were hip fracture patients, although they did include some elective hips and knees in there. As you guys know, it reduced the risk of VTE. Importantly, in this study, aspirin was given on top of heparin or low molecular weight. But what's important for us is that it demonstrated that aspirin did increase the risk of bleeding postoperatively. So the rate of bleeding in those who got aspirin was almost 3%, and in those who got placebo was 2.5%. The other thing that was interesting is they looked at the difference in bleeding rates, whether you were also receiving an anticoagulant in addition to the aspirin or placebo. So if you got aspirin and heparin together, your risk of bleeding was 3.5%. If you got heparin alone, so you were in the placebo arm, that risk of bleeding was 2.3%. If you got aspirin alone, you had about 2.5% compared to 2% with just the placebo. So it suggests that adding an anticoagulant to an antiplatelet does increase your risk compared to either of those strategies alone. So when I think of Jill's dad, it's intuitive that adding an antiplatelet to his VTE prophylaxis is going to increase his risk of bleeding. POISE 2 is always the study that's cited when we talk about aspirin management perioperatively. This was a large double-blind randomized controlled trial. What they did is they took patients who were undergoing, that's not vascular surgery, it should be non-cardiac surgery, and they were randomized to receive aspirin or placebo. The aspirin was initiated immediately before the procedure. They got a load of 200 and then 100 milligrams thereafter. And people who were already on aspirin, they got 7 days of the study drug and then they went on to their usual regimen. If they weren't on aspirin going into the procedure, then they got 100 milligrams for the full 30 days. And what they showed is that aspirin did not reduce the risk of death or non-fatal MI, but it did increase the risk of major bleeding. Now, the nice thing about POISE 2 is you can use it to defend your position on whether you're for or against continuing aspirin perioperatively. So when they did the subgroup analysis in those continuation and initiation strata, so the people who were already on aspirin going into trial versus those who weren't and were started for the first time, what they found is that the people who were on aspirin before the study, continuing the aspirin was not associated with an increased risk of bleeding in that subgroup. Now, and that's for major bleeding. If you look at the composite, though, of life-threatening and major bleeding, there did seem to be a significant interaction there. And then the other big question that came up was, what do we do with stents? Like people who have a prior percutaneous coronary intervention, they're usually on an antiplatelet lifelong. So what do we do in that subgroup? In POISE 2, there was only about 400 patients who had a stent going into that surgery. These weren't recent stents. These were at least a year out from their procedure. And what they showed is that in that subgroup, aspirin did reduce the risk of cardiovascular events, and they didn't see a significant change in bleeding. So as a result of those conflicting results, depending on whether you're looking at the continuation versus initiation strata, the guidelines vary significantly. So the Americans say we recommend against initiating or continuing aspirin in most patients, with the exception of patients who are going for carotid surgery. The Canadians take a very similar stance. They also add in, if they've had a recent cardiac stent, you should maybe consider not discontinuing. But then chest couple years ago came out with a very different recommendation, which was to continue aspirin perioperatively, and now is based on that subgroup analysis comparing the continuation versus initiation strata, where they didn't see an increased risk of bleeding in a continuation group. But I think probably the most balanced approach is that from the Europeans, and they say if the patient has had a prior percutaneous coronary intervention, you should continue the aspirin. In the patients without a history of PCI, they suggest discontinuing, although it is a weak recommendation. And then finally, they put this really important caveat is that if a patient is at a very high risk of bleeding, you should consider interrupting for at least 7 days. And the reason why it's 7 days is that's how long it takes for a platelet to turn over. Okay, so that's how things, I guess, stood until 2022. This study just came out recently, relatively large randomized controlled trial performed in Korea. They took people who had a drug-eluting stent placed at least a year before entry into the trial, and they randomized them to either being on no antiplatelet going into surgery, so that was the intervention group, versus being on aspirin alone. And they included people who were on DAPT or monotherapy before entering the trial. And what they found is that there was not a significant difference in cardiovascular events when you look at the group that got aspirin versus no antiplatelet. There was not a significant difference in major bleeding, although the absolute difference was about 1%, which is similar to what was seen in POISE 2, but the risk of minor bleeding was significantly different. And when we talk about minor bleeding, they're talking about a 40-point drop in hemoglobin if it's not clinically overt, or a 30-point drop and there's signs of bleeding. So take it with a grain of salt. Minor bleeding is really not minor bleeding. It's probably clinically relevant. So I would say this is an inconclusive trial. It was underpowered. The event rate was much lower than expected. When they did their power analysis, they were expecting a 6% event rate in the aspirin group versus a 12% in the placebo group for their primary outcome of cardiovascular events. So I don't think we can conclude from this study that holding aspirin does not increase the risk of cardiac events, but it does confirm what other studies have shown, which is that aspirin increases perioperative bleeding. So what about our other antiplatelet agents? So these are the CHEST guidelines. We chatted with the aspirin already. Ticagrelor, this is a reversible P2Y12 inhibitor. They recommend a 3 to 5 day duration of interruption. Now in practice, most of us are doing 5 days because that's in keeping with the ASRA guidelines. Plavix's recommendation is to hold for 5 days. No one's using prasugrel here. Interestingly, they talk about Cangrelor. We don't have that here, but the Europeans do talk about using Cangrelor, which is an intravenous P2Y12 inhibitor, as bridging for the highest risk patients. But that's not a strategy that we can employ locally. Now, I chatted earlier that your risk of having a major cardiac event is highest if you've had a recent event or a procedure. So these are the recommendations from the Europeans about what to do with aspirin or other antiplatelets in patients who had a prior stent. Importantly, you need to consider, did they have an acute coronary syndrome, and was that the indication for the stent, or did they have other high-risk features, like was a left main stented, was it a chronic total occlusion, was this a recurrent MI, do they have a history of prior in-stent thrombosis? If the answer to that is yes, then ideally we should be waiting 12 months before proceeding to elective surgery. If it's a time-sensitive surgery, that duration can be shortened to 6 months or even 3 months for the most time-critical procedures. On the other hand, if the patient is going for elective, or if the patient had an elective PCI, so they're having angina, but it's not an acute coronary syndrome, in that case, they recommend ideally waiting 6 months, but you can shorten that duration to 1 month for time-sensitive procedures. And then finally, I just want to talk about kind of this conundrum of what do you do with antiplatelets when a patient is on a direct oral anticoagulant for VTE prophylaxis. So the EPCAT trial, which I'm pretty sure most of the orthopedic surgeons are familiar with, they took patients who were undergoing elective hip or knee arthroplasty. They got 10 days of rivaroxaban, 10 milligrams up front. And then after that, they were randomized to either aspirin or Riva. They got 9 days if they were a knee and 30 days if they were a hip. And the study showed that there was no significant difference in the rate of VTE between the two groups. In fact, using aspirin alone was non-inferior to using Riva. And they didn't actually see a difference in bleeding between those two approaches, which was a bit of a surprise, honestly. Oh, shoot, I had a slide looking at the subgroup analysis for if there, oh, here it is. Now, if you look, though, at the patients who were on long-term aspirin coming into the therapy versus those who weren't, the people who received Riva and aspirin together didn't actually have a different rate of major bleeding compared to those who were on Riva alone. So hopefully this means that I wasn't the one who made Jill's dad bleed. So key points, I hope I've emphasized that in addition to balancing the risk of thrombosis and the risk of bleeding, we should also be considering the implications of surgical delay when we're deciding what to do with aspirin in pre-op clinic or when we're working on the consult service. I've highlighted a few of the indications where you may consider surgical delay. So for instance, if you've had a stroke in the last 6 months, if you've had an acute coronary syndrome, you should ideally be waiting a full year. And then if it's an elective PCI, it should be 3 months ideally. In terms of what to do with the aspirin, I think the evidence is clear that continuing aspirin increases the risk of bleeding. So in patients who are not at high risk, interruption, I think, still makes sense despite what the CHEST guidelines say. On the other hand, in patients who have stents, the evidence isn't definitive, but I think at this time it makes sense to continue aspirin in that patient population. And then finally, the other antiplatelets, clopidogrel and Plavix, generally speaking, we should be holding these perioperatively because they significantly increase the risk of bleeding.
Okay, we're almost done. I only have 10 slides, so this will be very quick. My name is Henry B. I'm one of the staff anesthesiologists at the UFS. Welcome everybody today to our joint grand rounds, which we've been doing in collaboration with all 3 departments for many, many years now, and it's always a real treat to see everybody. And just another special plug before I start for the huddles that we do every morning. I think it's fantastic, and then it's definitely improved patient care, and a big pat on the back for everybody for attending. Most of the time it takes, like 5 minutes, if anything less, but I think in that short, brief period of time, we're able to have much better collaboration and communication regarding planning, surgical planning for the patients that we all share. So I'm only going to talk about 2 things. One is I'm going to very quickly just talk about ASRA and explain why there's a little bit of less so now, but there's still once in a while we'll see a little bit of confusion between what internal medicine might order for stopping certain DOACs and as well as what anesthesia would like for a neuraxial surgery. And I'll just very, very quickly kind of touch on that. And then we'll talk about how to thinking about reversing DOACs, especially for like more emergent orthopedic trauma procedures. So all of my information have QR codes. If you want to read this article, I don't know how to do it on Zoom, but if you're here in live, you can just do the QR code thing and it will pull up that article. But essentially, this is like the most recent guideline from, I guess, what they would consider like, like the holy grail of like information that guides anesthesia with regards to management of thrombolytic medication before any surgery, really. But specifically, it's a lot of the time it's for orthopedic procedures. So this guideline came out a couple years ago. It doesn't fully encapsulate some of the slightly newer studies that have since come out, but it does definitely weigh in on a lot of the studies that have been leading up to this since the introduction of DOACs. And it also recognizes its own limitations because a lot of these recommendations you see on there with rivaroxaban and pixaban being held for 72 hours are grade 2C evidence, which is not super strong evidence. And there's one of the confusions sometimes we have, including myself, is do you hold it 72 hours from the first half-life of the last dose, or do you hold 72 hours from the last dose taken? And if you actually read this guideline, it pretty well clearly states it's 72 hours from the last dose taken. So you don't, like, let's say the surgery is on the 28th, you count back 27, 26. You don't have to let them take the last dose on the night of the 24th. The morning of the 25th is the 72 hours before. And if stopping it too long definitely does put them at risk of stroke and things, right? And we don't want that. So I only have 2 points in there. It's very easy to remember, 72 hours. And if there's any confusion in the pre-assessment clinic, once again, something that's easily mitigated with just good communication, double check with your internal medicine or GIM colleague. They're always just literally next door. And we'll let you know, like, yeah, this patient will be a really good candidate for neuraxial. We've chatted that with them. Can we stop it for 72 hours versus 48? So that's just like a little plug for that. This is a study. It's kind of got an unfortunate name, but this is a newer study. It came out 3 years ago. A little bit newer than like, what's that other one? Is it Prospect? Pause. Yeah, a slightly newer than Pause. So Pause is a study that, I don't know how many of our anesthesia colleagues have read that one, but it came out, I think, in 18 or 19. And it was one of the first ones that was done in a really good way, where one of their non-primary outcomes, but like something they just studied on the side, was looking at plasma concentration of apixaban 48 hours before, if you stop it 48 hours before surgery. And they found that some of it is like in the vast majority of patients, not all, in the vast majority of patients, the plasma concentration was under, I believe in that study, it was under 50 nanograms per milliliter. And they do actually also omit 2 things. One is they randomly picked 50 nanograms per milliliter. And 2, there's 0 correlation between 50 nanograms per milliliter and the risk of poking someone in the back. So it really is just like, it's like the trick trial. They randomly just picked 70. So they randomly just picked 50 nanograms per milliliter. This study uses 30 nanograms per milliliter as a threshold for what they would consider risk of poking someone's back or bleeding or whatnot. This 30 nanograms per milliliter, although not correlated in any study with spinal hematomas and things, which are really rare, and I don't think you can ever actually do a study like that, it is based off of the data that comes out of thrombosis, like international thrombosis guidelines and hemostasis guidelines. So it's a little bit more legit in terms of the concentration. And if you look, within 48 to 60 hours, there's still like somewhat of a significant percentage of people who had detectable levels greater than 30 nanograms per milliliter. But by 72 hours, pretty well, you're looking at the red thing, the red bar, you pretty well don't have anybody. So I guess in some ways, the study does show that, like, yes, it echoes the belief that likely in most people, like, especially because in this study, they looked at 5 milligrams twice a day instead of 2.5. And for those of people out there who are like me, dumb but too embarrassed to ask, the reason to, like, some of the times when we go and do PAC clinic, you see people on 2.5 milligrams twice a day. They have to meet like a specific criteria, right? Specifically, 2 out of several criteria have to be met, at least 2. Things like age greater than 80. Correct me if I'm wrong, guys, but I think age greater than 80, weight less than 60 kilograms, and then creatinine greater than 133, I think, is something like that. You have to have 2 out of those 3 met before you're considered on low dose apixaban. But to note, on this graph, they're talking about 5 milligrams twice a day. And so, well, That's pretty great. I made this like at midnight last night, so it was funny to me at that time. So I'm just gonna talk really quickly about, so like when I did a talk similar to this when I was a resident, and I remember looking at that time, and that was when the dabigatran antidote had already come out, and they were still studying andexanet. And in my vague recollection, andexanet got canned in like phase 3C because there was too much risk of thrombosis. So I was actually like very pleasantly surprised when for this talk, I looked it up again, and it's been Health Canada approved. So I wasn't sure. So I texted Oksana like super late at last night, which I feel really bad about now. And in typical Oksana fashion, she texted me back right away. And she's like, yes, it has been approved, but it's not available anywhere. So that's doesn't really help us. But this medication is essentially, think of it like the antidote for rivaroxaban and apixaban. There's a couple reasons why when CADTH looked at whether or not the provinces should fund this, they denied it. So one of the reasons, hold on a second, I'll just see what my next slide is before oh yeah, okay. So most of the stuff they looked at came out of this study called Annexa 4. And that's probably the best study we have right now, looking at using andexanet to reverse apixaban and rivaroxaban, and then they study things like thrombotic risk afterwards, like how successful. And they basically kind of had this like claim that like it had really good outcome in terms of reversal in like 80% or above of cases, somewhere around there. There was 10.5% chance of thrombosis. And in this CADTH recommendation, they compared it to RETRACE-2. So RETRACE-2 was a study that instead of looking at using andexanet to reverse factor 10A, they used what we have now, which is like just using 4-factor PCC. So and the patient population they specifically studied was for strokes, brain bleeds. So patients coming in on apixaban, they have a hemorrhagic stroke. And they found that comparing them, they found that andexanet, which is designed to be a true antidote, is more effective at reversing. But the overall outcome in terms of mortality and morbidity was not significantly different enough to justify the cost of this medication. So that was a huge reason why they shut it down. And if you look here, it's also very complicated. So if someone's on dabigatran and you give the antidote for dabigatran, it's like, I think Oksana said it was like a one-time dose reversal. Whereas if you look at this, it's like more complicated than treating DKA, like it's like, and they give you all these, like, I hate it when they give you these super nebulous ranges, which confuse you. Because chances are if you're doing this, it's like 3 a.m. and you're scared. Like, then you're like, do I go, like, what physician in their mind is going to be like, oh, I'm going to pick 4 milligrams. Like, everybody's going to be picking 800. Everybody's going to be picking 8 milligrams per minute, right? Who's going to be setting a timer for 120 minutes? Like, it's just really, really convoluted. They didn't design it to be easy to give. So you need a loading dose, and then you need an infusion dose. That's how you administer it. And they come in small vials. So you actually, like, per average treatment, you need about 5 to 9 vials. I have no idea why didn't they just give you like a big vial, but each vial is about $4,900. So combined, the average treatment you're looking at is like about $26,000, probably closer to $27,000. And because of the lack of data showing superiority over PCC, which is what we have right now, if you have a patient who comes in, they got shot, they're on apixaban, you would give them 4-factor PCC. There's really not a lot of data. I think down the road, because this is really new, down the road, we probably will see superiority data, but for now there isn't, and it wasn't enough to justify the cost. So that's why they have not recommended this medication, even though it's Health Canada approved. So don't call Oksana asking for it. It's not in the fridge for now. But I want to put a plug in for it because I think down the road it might be. They did mention that if the cost can come down 27%, it will justify the cost. That was on the very last page of this entire CADTH recommendation. They buried it because they didn't want to admit it. So it was great. Okay. So speaking of PCC, just a quick reminder, for people like, like me who've been out in practice for a long time, haven't read anything and forgot what the 4 factors are. It's factor 2, 7, 9, and 10. And I remember studying for the exam, just memorizing the year 1972. And then, so those are all your anticoagulant factors, right? It also has 2 procoagulant factors, which is protein C and S, and it has a little bit of heparin in there, which is why this is contraindicated if someone already has heparin-induced thrombocytopenia, which is probably actually the one single major contraindication for it. So the 2 big indications for using this classically is, let's say someone comes in on warfarin and they're at risk of significant bleeding. And the way they define it is like any bleeding that is potentially fatal or like super symptomatic and you're in a critical area of like operating in a critical area. Or I think the easier to remember for us is if you plan for the hemoglobin to drop greater than 20, it's equal or greater than 20. I didn't know how to do the equal sign. Or transfuse 2 units or greater of blood. So that's how they categorize it. Or if you want to reverse warfarin in a pinch and somebody requiring more urgent surgery, but not like, got to go to the ward right now, you have about 6 hours. So what they recommend then is you give vitamin K, which takes about 6 hours to work anyways, but then you give them PCC at the same time, which has a half-life of 6 hours. And the reason the half-life is so short is because it's rate limited by factor 7. Factor 7 has a very short half-life. So by giving them together, the recommendation is that then you have this nice little bridge, and you're kind of covered for during most operations and a little bit afterwards. So in special populations now, like which is what we're talking about, almost a little bit like off-label, right? Talking about PCC. The reason it's special is really because there's really no randomized control trial at all that evaluates efficacy or safety of using PCC to reverse things like rivaroxaban or dabigatran. Sorry, or apixaban. But we do it anyways because it's like the best we have right now. So it comes in a couple doses, and I double checked this with Oxana. If you pick whichever one of this on there that you're gonna remember the best at like 3 a.m, and you're like, there's like a rupture AAA. So the guidelines say 2,000 fixed dose. So you can just that's like an easy to remember number. If you're the kind that really enjoy weight-based dosing, then 25 to 50. And the range is dependent on, once again, when the patient took their last dose, if they're on 5 milligrams twice a day, 2.5 milligrams twice a day. I think it's just really, anytime you look at that range, I don't like it, but if you want to, that's the range they give. But they do, talking to Oksana, like you can definitely just give 3,000 international unit. Especially if you're just really, really like don't want to think and you're like, we got to stop the bleeding. So the risk of thrombosis with this is about 1.4 to 4.2%. And then my last slide is more so, I just want to put a plug in. This is a website called Treat the Bleed. It's a really good website. So Oksana wanted me to give a plug for this. And initially I was like, I don't know, there's a lot of reading. And then I looked at it and it was actually like amazing. Like it has a lot of like super easy to read charts for people who are like not smart like me. And or if you're just like really tired on call and you don't want to read through like a bazillion words, it's got really nice ACLS style like flow charts, like do this. If yes, go to this. Like it's awesome. So I would strongly encourage anybody, if you're on WebEx land, just go to Treat the Bleed. I think Oksana wrote a section of it. I don't know which section, probably the smart section. And but it's awesome. Like I went through a couple sections and it actually in a pseudo choose your own venture form kind of actually like helps you. It helps you and it not just helps you, but it also kind of like does so in like a inquisitive way that like asks you questions, challenges you to think about like what decisions you're making. But if you have some downtime today or anytime, just go through this website. It's really helpful. So that's it. That's all I have.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.